This is an interview with Dr. Stanley Foster about his activities in the West Africa Smallpox Eradication Project. The interview is being conducted at the Centers for Disease Control and Prevention as a part of the 40th anniversary observance of the launching of the West Africa program. The date is July 14th, 2006, and the interviewer is Victoria Harden. Dr. Foster, would you begin by just briefly describing your childhood and your growing up and who made you who you are?
Okay. I grew up in Melrose, Massachusetts. My family was fairly religious. My father died when I was 9 years old. And one of the things that happened soon after that was I met Gordon Seagrave. Now, Gordon Seagrave was the famous missionary surgeon whose Burmese nurses provided the medical care to Stilwell's troops during World War II. And he was really my role model. From that stage on, I was going to be a doctor. So I went to Williams College and then went on to the University of Rochester. And I think the connection to CDC was through DA, who also graduated from Rochester, as did Dean Hutchins. At that time, they were drafting doctors, so I came to CDC.
And let's get a date here. This was in the early
62.
62. Okay.
62. They were drafting doctors, so I decided I'd rather come to CDC than go in the Army. And I came here, and one of the interesting things that sort of started off was with two F names. Bill Fagey and I sat next to each other in the EIS class of 62. And I was assigned to the Indian Health Service in Arizona and carried out a number of epidemiologic studies. My basic assignment was for trachoma, and where at that time about 22% of the Indian children had trachoma.
Had you specialized in infectious diseases or anything in your
Internal medicine was my field. It was my field at that time. And as was often the case, Alex would try to seduce officers he wanted to stay. So
Alex Langmuir.
Alex Langmuir. He sent me to Bolivia to investigate an outbreak of conjunctivitis and Peace Corps volunteers. I came back to my home in Phoenix, got to Atlanta at about 3 in the morning, and at 6 o'clock in the morning I was on a plane back to Phoenix and on the way to the Truk Islands in the South Pacific. And that was probably one of the most interesting of the outbreaks that I did. I did a total of 18 outbreaks over 2 years. But that outbreak was an outbreak of diarrhea, and affected all age groups, and with deaths in young children. And it was epidemiologist paradise, because a boat would only go out to an island once a month, and you could know the entry point, and there was a health worker there that would write down the cases and the names. And we brought back the specimens, and the lab tested them out, and it was a great epidemic, and the pattern of transmission was influenza, but the disease was diarrhea. But they couldn't come up with an agent. So we tried to write up the article several times, but without an agent we couldn't. So many years later, when I came back from Bangladesh in 75 or 76, the lab called me and says, "We just found out what your 64 outbreak, it was rotavirus." And so we pulled out the article and finished the article and published it at that point in time.
We should talk about a rotavirus vaccine later on. So you were doing epidemiology up until 1966, and
well, no, that's not quite true. I did my EIS from 62 to 64.
Right.
And then I left CDC and went back to Rochester for a year residency, and then went to University of California in San Francisco and did a fellowship in pulmonary disease. And probably would have stayed on in San Francisco in pulmonary disease, and got the call from DA. He said, "Do you want to go to Africa and get rid of smallpox?" And my wife and I thought about it, and we decided after 24 hours that was right. And we had 3 kids at the time, and I think one of the things we need to discuss is wives and kids.
Yes.
In terms of the impact of those experiences on the kids. Let me just handle that now. 3 or 4 of my kids' careers developed out of experiences in smallpox. My oldest son was interested in traditional medicines, and he now does internet work in China. My second son, when he was in the 8th grade in Dhaka, Bangladesh, he did a study of rickshaw drivers and how much of their income they spent on food. Now he's the chair of the Department of Economics at Brown. My third son got his start really in 1974 in Bangladesh, when we had a tremendous famine and people were dying on the streets in front of our house. And he decided to go into medicine, but I had no knowledge of the impact on him until I read his Peace Corps application. And then I understood that experience back in 72 or no, 74 was the major thing that sent him to medicine.
That's very interesting. And you said you came from a religious family.
Yeah.
You have missionaries or
no? Well, my
ministers
wife's folks are missionaries. They went to Guatemala on their honeymoon, and her mother was interesting in that she refused to go as a missionary wife. She said she'd only go as a missionary, and that was back in the 20s. And they went down to Guatemala and learned Spanish, and then they learned Mayan, put the Mayan writing into written language. Then they translated parts of the New Testament. They had a school and a clinic and everything. They stayed on there for 45 years. And then every year or two, my wife and I go back to that same group. My wife is fluent in the Mom language, so we go back and we have a nurse we work with, and she tells us what she wants us to teach. So we do that every year or two.
I'm interested in the streak of idealism and this
Oh, well, you should get a copy of my college caricature.
All right.
Because, and I have a digitalized copy, I'm sitting in a pot in Africa with the pygmies standing around, bless this food to our use, and Dr. Stanley, I presume, at the bottom. So I did have a missionary bent at that point in time, and so that was captured in my college caricature.
I'm seeing a different type of person who has been involved here at the CDC with the smallpox than what I have seen with my investigators at NIH and the things that motivated them to go into research. It's
yeah, you probably interviewed one of my friends, Harvey Alter. Did you ever interview?
I know Harvey Alter very well.
Yes, Harvey was an intern when I was an intern at Rochester.
Indeed. Let's talk about once you were recruited into the program, they asked you apparently to recruit others as well. And you mentioned that the recruitment of this one
Diego was
interesting.
Yeah, it was very interesting. Andy was a public health advisor and a good mechanic, and I remember I met him at a building in San Francisco, and he walked in, he said, I saw this advertisement that you wanted a public health person who spoke French and was a good mechanic, and I know you needed me. That was it.
Very confident.
Yeah, there was no question about it, and Andy turned out to be one of the best. He worked for a long time in West Africa, and then he was working with smallpox in Afghanistan. Then he came to, he was getting bored with Afghanistan. I brought him to Bangladesh. Then he worked for many years at the Carter Center and was very close to Jimmy Carter and did a lot of agricultural stuff and really worked incredibly well with the Carter Center. And then he took a job in Nigeria and he died about a year ago.
You were sent initially. You were the medical officer in Nigeria. Would you tell me which region you were in and
well,
what
I was responsible for the whole country. And there were we had at that time Nigeria had 4 regions. the western region, the Midwest, the eastern region, and the north. Mm-hmm. And obviously half of the population was in the north, and about half in the south. And we had Margaret Grigsby and Jim Lewis for a time in the western region. Warren Jones was in the Midwest, and Bill Fagey and Dave Thompson and Paul Litchfield were in the east. And then Dean Hutchins and Vicki Jones were in the north. And it was very different program in the north and then in the south.
Would you tell me about that?
Yeah, in the north, the traditional leadership was incredibly strong. I remember the first village I went to in Guatabawa in '66, and I got there at 6 in the morning, and there were 6,000 men in a line. And we vaccinated the men, and then they went home, and then the women came out. Well, for the women to come out was a big social occasion. They really didn't want to go back in. But I learned something that day which very interesting. It was a big district, and I told the district head that that we should have 3 vaccination sites in his town because it would take us too long to do it at one site. He said, "I forbid you for doing that." He says, "Everybody has to be vaccinated in front of me. Nobody will tell me that they were vaccinated if it had to be in front of me, whereas if there were 3 sites, they could be vaccinated at another site." And you see, the emirs were really powerful people at that time. The emir of Sokoto, Katsina, Kaduna, Kano, these were very powerful people. The emir of Sokoto would ride around in his Mercedes every night, and if there was no petrol, the Mercedes got pushed around town. But he was very powerful, so that the only thing that you had to do in the north was to convince the emir, and he would call in his district head, and then everything would happen. And it was, I mean, it was easy to get 96 to 98% coverage in that region. In the south, it was much more difficult. People would not go 200 or 300 yards for vaccination, and so in the south, people were much more independent. There was not the structure, and it made it much more difficult to get people to come for vaccination.
Why would they not want vaccinations?
Well, I think if you go historically back, there was a demand for injections. And we believe that occurred secondary to the yaws program, which gave shots of penicillin to treat yaws, but it cured venereal diseases and pneumonia and everything else. So injections were always sought after. And I think in the north, the structure was such that people would be told to do it, and they'd do it. In the south, you had to really convince or use enough publicity to get people to come for vaccination. So it was a totally different thing. And the epidemiology of measles was different. In the north, where the women are in Purder, where the population density was relatively low, the median age of measles was about 36 months. In Lagos, where you have mothers carrying their babies on their backs to market, the median age was around 14 months, and then that was with a population of 600,000. When I went back in the 80s and 90s to Lagos, which now has a population over 10 million, possibly 20, the median age had dropped even further to around 14 months, and I mean to 8 months, and it made it much more difficult.
What was the toughest problem you encountered?
Oh, the Civil War, the Biafran Civil War. Actually, I had flown to Benin to see Warren Jones there, and I got off the plane, and Biafran hijackers got on and hijacked the plane. And that plane later was used to bomb Lagos. And it was very interesting because we believe that they were using a passenger plane as a bomber, and we believe that they were defusing the bombs and they were throwing them out the door. We felt that probably the reason the plane exploded was because the bomb went off before it got out the door. Of course, they had to find somebody who was asleep at their gun to reward for shooting this plane down. but that was tense, and a lot of people were evacuated, and it was tense. And I was talking with Dean Hutchins at lunch. We actually I took the kids and my wife up to Kaduna, for I thought it was safe, and the next day they bombed the Kaduna airport. So, but one of the interesting things at that time, we knew there was not smallpox in Biafra, but I was really afraid that smallpox would get into Biafra, and so I convinced the government that the safest thing for them to do was to vaccinate a large area around Biafra so the smallpox wouldn't get into Biafra, and that way we kept it out. Okay. And then we also did a lot of vaccination of children coming through the lines, and the malnutrition in pockets of Biafra was just absolutely terrible. Yes. And I think the war was really the toughest obstacle. I mean, the regional office was shattered by the bombings in Lagos, and it was not as safe a place as it had been before that.
How did you get along with your counterparts?
Oh, I had the most wonderful counterpart in the world. A fellow by the name of Yemi Ademola, who had gone to Harvard School of Public Health. And if you go back into the history of the smallpox measles program, which I will cover tomorrow morning, wanted to do all the countries except Ghana and Nigeria. And Ademola was one of the ones that pushed. He actually went and met with Kennedy to try to push that, and he was just so honest. He looked out for the poor. For example, he had a grain bank where he would buy produce when the price was low, and then they would sell it when the price was high. So a cooperative. He supported a clinic. He was just an absolutely wonderful guy, and he also was my neighbor. So he and his British wife, we'd often go out and have tea. And also, he was the most traumatic part of it. I got a call one night about 3 in the morning that he had been attacked, and he had been macheted across the neck. And I went in and tried to save him, but I couldn't. And at that time, I mean, all I was thinking of him, my wife was pregnant, she started to abort. It was a horrible day, and then the next day the police came and they wanted to put me under arrest. So that was one of the most traumatic events, the single most traumatic event of my years in Nigeria. We had a incredibly interesting team. We had Dean Hutchins and Vicki Jones, and my favorite story of Vicki was Vicki went out in the field once for 4 or 5 weeks, and she'd either broken or forgotten her mirror, and she came back to Kaduna and looked at the mirror, and she said something's wrong, and then she realized it was her face was white. In other words, she'd only seen black faces for 6 weeks, and she just didn't. But she was wonderful. And the teams in the north were just absolutely extraordinary people. They had a driver there. He would know when he went into the village, who do you see first, and who do you see second, and who do you see third. And he had driven for a political figure before that, and was just good. But the teams would go, and they could vaccinate with the jet injectors 8,000 to 10,000 a day, and the most I ever remember vaccinating a day, once in the Midwest with 4 lines, we vaccinated 14,000.
Wow. And
I think that I think it's important to put in perspective India in this, because India had vaccination numbers greater than the population, but they still had lots of smallpox. And so Henry Gelfand went out there and did an assessment, and he found the vaccinators were vaccinating the school children regularly so that they would get high numbers of vaccination, but coverage was very low. So when we went to West Africa, we were absolutely sure that with high coverage and coverage surveys, which Rafe and others developed, Don Edens and Rafe primarily, which was adapted out of a U.S. survey, that if we got high coverage, we would stop smallpox. There was no question about it. And that was our strategy. And we were absolutely sure that high coverage with the jet injectors and coverage surveys, if we got above 95% coverage, or 90% or even better, we'd stop smallpox. And there were really 4 or 5 major events that led to the change in strategy. The first was when we first arrived in Nigeria, there was an outbreak in eastern Nigeria in Agoja where Bill Fege had been a missionary. And they had a limited amount of vaccine, and by focusing the vaccine on the affected area, they stopped the outbreak. The second important thing was a series of spot maps that Bill Fege drew. And Bill doesn't remember this, but I remember him sitting there, and each year the smallpox would come from the north, and there'd be a few outbreaks on the north border and the east, and then it would increase in number and frequency, so you could just see it spread down. And by having these monthly maps, and I remember sitting on the steps and looking at these monthly maps and seeing how the spread, and the question came up was, if we stop these first few outbreaks, will we stop them all? And the third major event in the shift in strategy was occurred in Abakaliki. And in Abakaliki, there's a nice paper about this by Dave Thompson and Bill. They got over 90% coverage. They'd done a coverage survey, and all of a sudden they had an outbreak of smallpox. And there was, this is called the Faith, I think it's Faith Tabernacle. It was a religious group that had refused vaccination, and even though the coverage in that area was 90%, the small group of unvaccinated people were able to sustain an outbreak. So in my opinion, those were the major events that shifted in the strategy from mass vaccination and surveys to surveillance containment. And that was certainly a major shift. And I think although the diseases are differently, when you compare this to malaria, malaria was such a centrally directed program, and they never really responded to the signs of drug resistance and insect resistance. And so those sorts of things happened. Whereas here, people realized from the data, and I think when I teach on lessons learned from smallpox, measles, one of the major things is learning from our mistakes and being willing to learn from our mistakes. And my favorite story on this, although we're out of sequence, I tell it this time, is a story about Sabur. And Sabur was one of my team leaders in Bangladesh. And at this time, India was free of smallpox, and we were still having trouble. And I went up to see Sabur. He was near the Indian border, and if we did everything right, once we found an infected village, there would be no cases after 14 days, after one incubation period. So I asked Sabur, I said, Sabur, how many outbreaks do you have? And he said 16. And I asked him how many had gone more than 14 days. And he said 11. Well, this was a disaster, because they could have walked those cases across to India where the reward was big, and made a lot of money. And so I said to Sabur, what are you doing? His response was, I'm doing everything the book says. I'm putting the patient in the house. I'm putting a guard at the front door and the back door. I have an extra guard at night to keep the guards awake. I'm vaccinating everybody in the household. I'm vaccinating everybody in a half mile, and I'm searching every place in 5 miles. And then across a cup of tea, incredible smile. And he said, today I found out why. And I'm going in and I'm asking for a list of visitors. They are not giving me the names of relatives who came to visit, because they don't consider relatives as visitors. And so we added a list of relatives to the procedure and solved the problem. And I think that this is really one of the main points to get at, is that a lot of us at CDC and who are in leadership positions got a lot of credit for smallpox eradication, but it's these people who work 28 days a month in the field, month in and month out for 5 years, some of them. And and the other lesson to get out of this was to give somebody at the field level the ability to assess their own performance. And then when they didn't meet it, they asked the question of why and came up with a solution. There's one other great story of a similar kind, which is really important. Bill may tell it to you. But at the critical time in the program in India, the things were going to hell in a basket in Bihar, and the numbers were going up. And the minister said, I'm sorry, no more surveillance containment. We're going back to mass vaccination. And Bill spent the whole weekend with the minister and trying to convince him and not. And he got up at the Monday meeting and he said, I'm sorry, WHO has recommended we continue to do this, and but I can't stand the political heat anymore, so we're going back to mass vaccination. In the back of the room, a hand raised, and this man got up and said, Mr. Minister, I am a poor country doctor, but when we have a house on fire in our village, we direct the water at that house. And the minister said, you have 1 more month. Unfortunately, over that month, things got better, and so they continued surveillance containment. But both of these examples illustrate the really major contributions that poorly paid and unrecognized field workers really deserve a great deal of credit for what went on and the success achieved.
But don't you think it was also remarkable to some extent that the bureaucracy and the people at headquarters were flexible enough to ask for and act on that kind of information? Many times you get bureaucracies, they know best no matter what's coming in. And I think the synergy was quite remarkable.
Well, I think that's the main difference between smallpox and measles. In other words, the smallpox program was willing. There's another example that I will show tomorrow. When we introduced the reward for reporting smallpox in Bangladesh, I introduced a single reward, and after about 6 months, only 35% of the public knew about the reward. And then all of a sudden, I discovered my mistake, and was that none of the health workers were telling the public because they didn't want the public to claim the money. So we doubled the reward to pay both the health worker and the public, and within 4 or 5 months, 80% of the country knew about the reward.
So getting the word out and knowing how the culture operates also played a huge role.
And
we went to South America, and I got some.
Are you ready?
Are you ready?
Yeah, we're all
Okay. One of the little side things was they used to say that working for the smallpox program was the best form of family planning, because at least their wives didn't get pregnant. There were, as you look at the evolution from West Africa to the rest of the world, it's a steady thing. And clearly when surveillance containment involved, and probably the best place it was demonstrated was in Sierra Leone, where Johns Hopkins didn't have enough material to do the whole country, so one side he did mass vaccination, the other he did surveillance containment, and that was the very important. Secondly, the legacy of surveillance containment out of West Africa clearly was key to the global eradication of smallpox. Had it not been, had it not developed, it is unlikely that we would have ever stopped smallpox in Asia especially.
What about the role of the bifurcated needle?
Um, well, I think if we go back just a little bit, if you go back to 1945 after World War II, smallpox was pretty much prominent in most places in the world, and especially in tropical areas where the liquid vaccine was unstable in the heat. So the development of the freeze-dried vaccine, where you could carry it in your pocket, didn't require refrigeration, and you could mix it up for the day and it would be good. So that was a big thing. And then the initial development of measles vaccine, and I don't know if you've discussed this story a lot.
A little.
A little. Let me just go over that a little bit, because the measles vaccine, Edmonston B, was developed, but it could only be given with gamma globulin. And it was not at that time licensed. It had been tested in about 20,000 kids. And at just about that time, there was a visit of 4 ministers of health to the states and NIH, and Harry Meyer happened to talk to them, and one of them got very excited and essentially said measles was killing 20% of the children in Africa, and that he could come and test the vaccine there. So the first year, Harry went to Upper Volta, now Burkina Faso, and tested the vaccine, and it proved its safety and efficacy without gamma globulin, and that was a major thing. And the demand was such that the next year they vaccinated 700,000 in Burkina Faso, and it was a tremendous success medically, politically, and politically. Yeah. And then the U.S. expanded to the other countries in OCCGE, and that was when CDC's first involvement. And probably the best story there is the Larry Alton story. Larry's the science writer for the Times, and he was sent out there, and he sent back a cable to Washington that said, the trucks don't keep the vaccine cold, and this sort of thing. And the cable came back from Washington, park in the shade. And so Larry sent a cable back, send trees. But then it expanded, and when you look at the different channels, in other words, you had the smallpox channel going on at CDC, you had essentially Harry Meyer's thing going on, and then the political thing of aid and measles. And for some reason, they thought they could vaccinate a fourth the first year, fourth the second, a fourth the third, fourth the last, and they would be done, which was totally totally wrong. And I was talking to Dave Sencer about a phone call he got when Curtis from AID called him and said, what about a measles eradication program? And Dave said, no, it can't be done. Measles control is all fun, but how about marrying smallpox and measles? And this was really the basis of a lot of the angst between AID and CDC, because essentially they paid the whole bill. And I was talking to DA last night and trying to clarify a few pieces of history, which is always difficult with DA. But it was interesting because when the U.S. first agreed to do smallpox, that was a briefing of the WHO delegation, and even the Secretary of HHS, I was HEW then, was not aware of this. And then, so then the announcement went out at the Assembly from President Johnson that the U.S. would support smallpox eradication. And then it was later when the smallpox-measles sort of marriage took place, and DA told me last night, which I didn't know, was that press release was written by Bill Moyers, which is very interesting. And that was the International Year of Cooperation or something like that, and so that was sort of the U.S. contribution to that.
Would you talk in a little more detail? You have mentioned the two women who were professionals in this organization. Neither of them is here for the reunion, but could you talk about who they were and
Okay.
how exceptional they were?
Yeah, two very different people. Vicki Jones, young, free spirit, guitar playing, and Margaret Grigsby, an older African-American woman professor at Howard, very prim and proper. I remember we had some issues with ensuring there was a proper latrine arrangement for her when she went to the field. And so, it was difficult in the area that Margaret was in terms of getting cooperation, the movement of people, and made it difficult. Though I do remember one early thing, the first outbreak I went to in the western region, I went there, and they had isolated the smallpox patients in a cocoa farm. And the only people who were allowed to go there were those that had the scars of smallpox, which is very, very interesting. On the other hand, you have the smallpox cult, Chopinot cult, where if you didn't want to get smallpox, you paid the priest. If you got smallpox and didn't want to die, you paid the priest. And if you died, the priest got all of your worldly possessions. So they couldn't lose. And there are historical accounts of in the 1800s of actually infecting people that didn't pay up by putting smallpox scabs on sticks going into houses. And I remember at the last outbreak I was working on in Togo. Actually, a couple of the traditional healers were there trying to pick scabs, but fortunately it was a vaccinio-modified case, so that it was not likely that there was much virus titer left in that.
What did Africa teach you about yourself and about public health?
I think if you look back at it, we were bright, we were young, we were not bright enough to say we couldn't do it. I mean, that was really important. In other words, there was never a sense that we couldn't succeed. That differed totally in Bangladesh. That was a totally different story in Bangladesh. But we learned as we went along. There was a good response on the people. We had pretty good government response and fairly credible civil service. At least we were paying per diems and that sort of thing, so it sort of kept people working. But it was a well-oiled machines. I mean, we had something like 80 Dodge trucks in Nigeria. We had lots of spare parts, and I think the last one I saw running was in the late 80s.
What kind of impact do you think the whole West African program had on the global eradication program?
Had West Africa, as I'll say tomorrow, had West Africa not succeeded, it's doubtful that the global program would have succeeded. I mean, I have no question in my mind that it laid the foundation. And one of the great injustices in the smallpox book is that the West Africa chapter is put after India and Bangladesh, which is extremely unfortunate and historically incorrect, because a lot of the lessons learned out of West Africa laid the foundation for what went on in Asia and Ethiopia and Somalia.
Indeed. Okay, we're almost done. Is there anything you would change if you were running the program all over again?
What we did then, we couldn't do now.
Say again.
What we did then, we couldn't do now.
Why?
I mean, it was pretty much an expatriate run operation, money-driven, technology-driven, and not did not have the proper amount of deference to local culture and societies and governments that
I wondered about that.
it was pretty much a technology-driven program, and it was marvelous in terms of the teams we had. In other words, some of the operations officers, Dave Bassett for one, George Stroh for another. George was driving from Joss down the south, and his motor mounts broke, and his motor fell out of his engine, and in the field he put the motor back in and drove home. I mean, just that kind of ability to react to the field. So that was important. In Asia, the key things were several. One was the monthly meetings were incredibly important, where people came in, they gave their reports, they shared their successes, they shared their failures, they got drunk, they sobered up, they got their money, they went back to the field. And most of them spent 25 to 28 days in the field. And as I look at CDC people going to the field now, they don't do that anymore.
We are just about out of tape, but I want to say thank you in case the tape does run out, and then ask you if there's any final thing that you want to say before we have a little time.
Yeah, I think I mean, the challenges of West Africa were nothing compared to what it was in Bangladesh, and especially in the floods of 1974, when the two remaining areas of infection were totally flooded out. The people went into motion, and we went from 89 infected villages in October of 74 to 1,500 the following May, and we were all depressed. We lost it, and a wonderful guy was my deputy, a fellow by the name of Rangaraj, who was the first Indian parachutist, and he had fought with Stilwell in Burma, and every morning he would say, "It's going to be all right, hang in there." And every day he was like that, and there was no rationale for that. And later on, when I was working in Somalia, I had beer with Rangaraj one night, and I said, "Ranga, how could you have been so optimistic?" He said, "I didn't think you had a chance in hell in winning, but when I fought with Stilwell in World War II, I learned that if you ever thought you'd be dead the next day, you would be dead." So it was his military training and his optimism that enabled us to keep going during incredibly difficult times, and
eventually to win.
Yeah, and eventually to win. And Ranga was, I mean, that was just his style, and it was incredibly important. And there were lots of people like that. In Bangladesh, we had 22 nationalities on our staff, and they're the best. I mean, they were family. I mean, we're all one family, and the key things, the monthly meetings were key. Surveillance got incredibly better. And we were able to track things, and we used money. I mean, the reward, we paid $25,000 in reward money in Bangladesh. And we learned, for example, when we started in Bangladesh, we were having trouble with containment until we started hiring people from the village. The reason we were failing was because health workers had no place to stay in the villages. Once you started hiring villagers to do the work, you had a place for your health workers to stay. And so there was a tremendous, and I think this sort of gets where In the north, in West Africa, you use the culture quite well. In the south, I think it was more the mechanical thing that I talked to of U.S. program operations.
Okay.
Okay?
Thank you very much. And there we
I think it was more.